All right, we'll go ahead and get started. Thank you for joining the Project Echo, the Telemed Project Echo that's sponsored by HTRC and the Missouri Telehealth Network. Happy New Year. So much has happened since we last met. I hope those of you who are in phase 1 have received your vaccinations. That's excited. I'm excited to say that my 95-year-old, well, he turns 95 Saturday, my dad will receive his vaccination on his birthday. So that's a gift itself. So more and more people are getting them, and let's hope that we can put this behind us eventually, whenever that is. So again, thanks for joining us this morning. We know that you're busy. I think we have an excellent Project Echo for you this morning. I'm Janine Gracie, Project Director for the Heartland Telehealth Resource Center, and I'm happy to moderate these sessions. But before we get started, I'd like everyone on this Echo to make sure that you do rename your name, and you do that by clicking on your picture, right click, and what will happen is a little box will show up, and we would like for you to rename and make sure that your state is after your name. So I will do that quickly myself, and boom. That just allows us to be able to answer your questions more appropriately, since we all may be from different states. And as you know, sometimes those state laws and regulations are certainly different in some of our states. So we'll make sure to recognize that. I'd like to start off with making sure that we introduce the hub team. So let's start with Karen.
Good morning, everyone. I'm Karen Edison. I'm the Senior Medical Director of the Missouri Telehealth Network and Show Me Echo.
Great, thank you, Karen. Rachel.
Morning, everybody. My name is Rachel Mutro, and I'm the Director of the Missouri Telehealth Network and Show Me Echo program. And also, I'm the State Director of the Heartland Telehealth Resource Center for Missouri.
Thank you, Rachel. All right, Tim.
Good morning. I'm the Telehealth Manager at Oklahoma State University Center for Health Sciences and the State Rep for Oklahoma as well, for HTRC.
Great. Are we missing Heather?
Yes, missing. She's not making it today.
Okay. And I see Evelyn and Robert haven't joined yet as well. So, but I did want to make sure that we recognize Trika. She is an outreach coordinator for Project Echo, and certainly has a lot of information on how to get more people to join our Echo. So she may be doing a little bit of chatting in the box to give us some ideas of how we can recruit. So thank you, Trika. That's wonderful. We have a smaller group today than usual. It's, you know, new year and new calendars and that type of thing. So we're going to go ahead and introduce everyone today because we have time to do that. So I am just going to start by calling out people as they appear on my screen. So Cece, you're first.
Hello, I am Cece Vangel. I am the Telehealth Coordinator for Show Me Echo and Missouri Telehealth Network. And I will pass to Cheryl Thurman.
Hello, I'm Cheryl Thurman. I'm a community navigator for Texas County and Wright counties, and I'm responsible for organizing their opioid task force meetings. So this has been very helpful for me. Thank you.
That's great. How about Sydney?
Hi, I'm Sydney Daniels from SEMO Health Network in Benton, Missouri. I do billing and chart audit and also anything else.
That's great. Thank you, Sydney. Jonathan, we'll get to you later. All right. Next will be Mila.
Hi, I'm a retired physician that's a board member for the Bluffs in Columbia, Missouri.
Wonderful. Thanks for joining us. Franz.
Hello, everyone. My name is Franz Kendall. I'm the Student Education Coordinator for Mid-Missouri Area Health Education Center.
Excellent. Glad you're here. Jill.
Good morning. I'm Jill Sigliana, Program Director at Memory Care Home Solutions, and we provide telehealth, mental health services, and occupational therapy for dementia and caregiver population.
Glad you're here, Jill. Excellent. Trika, you can go ahead and introduce yourself, even though I kind of gave you a shout out earlier.
You did, and I appreciate that. Hello, everyone. I am Trika Young, and I'm with the Missouri Telehealth Network. As Janine has mentioned, I'm one of the outreach coordinators here, and if you have any leads for to help me recruit for this ECHO, I'm going to drop my contact information in the chat. Please reach out to me. Thank you.
Thank you. Excellent. Tariq.
Hi, good morning. Nice to be with you. I am an assistant clinical professor and optometrist at the University of Missouri St. Louis College of Optometry. We are setting up, I've been granted permission to develop a telehealth course, and we're establishing a clinical complement with the teleretina service here at our partner at FQHC. So Tarika, I may be in contact with you about having students participate in some of these, if that's a possibility. And then I may be in touch with some of you guys to see if you would be interested in even guest lecturing in my course. So thank you so much.
That's wonderful. That was a great PSA for your course. That's awesome. You came to the right place. That's great. All right, Jerry.
I'm Jerry Wellmus. I'm a physician in Maryville, Missouri, and I work with Northwest Missouri State, Mosaic Life Care, and other entities. Probably all know Northwest Missouri is pretty rural, so and particularly the topic today, but all topics, I think telemedicine has been a huge boon. I want to say thanks and just follow up with you, Trika, to see if there's been any progress made from the other echo of that finder's fee I talked to you about. So. That's all I got. Sorry.
Excellent. Hey, Jerry's been helping us out with some videos and that type of thing to help us make sure that we can promote Project ECHO, and we thank him for taking the time to do that. Okay, Jim. Oh, Jim, I think you're on mute.
Sorry. Thank you.
There we go.
Yeah, I'm Jim Whitaker. I'm a semi-retired orthopedic surgeon in Kansas City, doing office orthopedics only and mainly at free clinics. And I am interested in the application of this whole telemedicine and how it's going to affect orthopedics, which is becoming more and more mainstream and accepted by people who don't like to change their habits, but they're forced to. So it's interesting to see it happen at this state level.
Great. Thank you so much. Christina.
I'm Christina King. I work at Blue Hill Counseling Services here in Sykeston, Missouri, and I am part of the IT support set.
Great. Thanks for joining us. Deborah.
Hi, I'm Deborah Edwards. I'm a St. Louis public school nurse, and I like learning.
Excellent. We're glad you're here. I think you'll learn a lot today.
Thank you.
Denise.
Hi, I'm Denise Graham. I work for Babylon Healthcare. We serve the Boot Hill of Missouri through telehealth. So I love this whole one. So interested to learn more. We have a hard time reaching out to the people in the boot hill. So
Yes, very good. Thank you. Susan. Or Helen.
I am Helen Nguyen, a retired physician, and I volunteer at the local free clinic in St. Joseph, Missouri.
Glad you're here, Helen. Thank you. Now, Susan, I saw that little mic go off.
Hi, I'm Susan Jacquino. I'm just a nurse in the community.
Excellent. Well, we're glad you're here, and you're not just a nurse. You are someone who is on the front lines, and we appreciate it. So
thank you so much. Thanks you for the class.
All right, before we get started with our echo, there are just a few announcements that I like to make sure that we do this appropriately, right? So we use first names during Project Echo. That just creates a more connected environment, and we want you to get to know one another and make sure that you are networking with each other as well. Please be conscious of any confidential protected health information. If you do share a case, which we would love for you to share a case at any time, but even in a question, make sure that we're protecting that information. We want you to ask questions, and we would love for you to do that verbally when the presentation is over. But if you are too shy or your connection is just a little shaky, you may certainly ask questions in the chat, and we will get to those during the question and answer session. Please keep your microphone on mute until you're ready to ask those questions, and reintroduce yourself. You know, make sure that you introduce yourself before you ask your question. These presentations and any materials that we have you know, given out even from April, okay, is on Box. So make sure that you do subscribe to Box in order to get that information. And if you have trouble doing that, Cece is a huge help, and she would be able to help you and walk you through that. The value in these echoes are the cases. So I do ask that, like, for next time, we're going to have a school-based telehealth presentation from Oklahoma. And so I just ask that if you have a question or a case about school-based telehealth, and you just have a, you know, an itch to create a case and say, hey, this is what's going on. My local school district's trying to connect to my clinic, and how could we do that? You know, create that case, and we can certainly discuss that. All right, so without much more delay, I'm going to introduce to you my friend and colleague, Jonathan Neufeld. He's the project director for the Great Plains Telehealth Resource and Assistance Center. We call it GP Track for short. He has consulted on a wide range of projects related to rural health and telehealth over the past 15 years. He presents at regional and national conferences, and published peer-reviewed articles in fields of telemedicine, as well as clinical decision support, mental health services, evaluation, and clinical outcomes. And so he's going to talk to us today about telehealth and mental health, maybe post-pandemic if we ever get there, and give a few pointers as he has learned throughout his career. So Jonathan, I'm going to turn this over to you. You can share your slides and we'll get started.
Okay, thank you, Janine. I am very excited, and I have to say, fairly nervous to talk to this group today. This is about as high octane a group of individuals on an echo call as I have ever seen. Not only that, but you've got a lot of variety here too. And this is something that in the world of telehealth, I think we're learning more and more and realizing, those of us who are in the business of kind of training and technical assistance and all of that, is that telehealth isn't one thing, never has been one thing, but we get a lot of questions that have to do, that are about telehealth. And we usually, as TRCs, I'm kind of speaking as a TRC here, we spend the first few minutes of every conversation figuring out, what kind of telehealth are you talking about? What kind of situation are you in? What state are you in, as Janine mentioned? What are you trying to accomplish? What sort of a facility? What's your reimbursement structure? Because all of those things matter. And I think the kind of take home of all of that, or what it reduces to, is the fact that telehealth is a tool. Like, let's just throw out there something like a wrench. And before if you're going to ask, okay, so what, how do I use a wrench? That's a great question, but there's going to be a whole series of follow-ups. What do you need to do with this wrench? What type of wrench are we talking about? Because there are so many different things you can do with a wrench. It's the same. I mean, you think about telephone or fax machines as tools as well. Can a fax machine save a life? Well, not by itself, but if you use it, you might be able to. And I'm sure there's someone has some story out there about when they got a new fax machine in the office and they figured out a way to use it and they ended up saving a life. I'm sure there's a story out there somewhere. Telehealth is the same way. It's a tool. It's a tool with a lot of different applications. And so as we are figuring out how best to apply this tool, one of the things we're learning is that there's a lot of good ways to use the tool. There are bad ways to use it, or inadequate or unhelpful ways to use it. But at its heart, it's useful in a lot of different ways. It's a flexible tool, and so it does a lot of different things. So there is never just one answer or just one way of thinking about it. What I have here today, and I'm gonna apologize right up front and maybe see if I can make amends here. I have a lot of introductory comments about telemental health and telebehavioral health in the context of the pandemic. And for some of you, that's pretty basic. For others of you, this might be pretty interesting. But what I'm hoping we can do, and I am very happy to do, is if I haven't scared you away, I will go ahead and run through my presentation and tell you what I came prepared to say, but then we'll have lots of time. We can talk about some details. We can do some Q&A. We can take it lots of different directions if you want to go different directions. But I have just some overview kind of comments. Talk about a regulatory framework. People who come to telehealth for the first time or come to telebehavioral health for the first time need to understand, what sort of a framework are we operating within, as far as regulation and reimbursement and all of that. And so I have some basic slides about that. I have some slides on individual clinical skills. I didn't think we would need to go there today, and so I'm probably going to stop after that first section, but we're happy to talk about that if it's something that's new to you. I suspect many of you already know about the telehealth resource centers. I'm one of them. Janine and Rachel are part of one as well. We are a great resource, and reach out to us when you can, and I'll leave that at that. And I probably don't have to say this either, but the pandemic has changed healthcare, not only healthcare, but it has changed the world of telehealth. Those of us in the TRCs are very acutely aware of this as we're writing our applications for the coming 4 years right now, recognizing that telehealth is not a niche option anymore. For so many years, we were trying to convince people, hey, telehealth is a thing. It's okay. You can get paid for it, and we might be able to do some good. Now, it's not just something that's nice to have. It's something that is going to be a baseline expectation of every healthcare organization going forward, even if we're not in a pandemic. It's going to be something everyone knows about, and that we are figuring out how best to use it. I probably don't have to tell you at this point either what kind of a hit healthcare took across the board. We haven't seen the full impacts of it. We're still waiting for damage reports and retrospectives and all of that, although it is starting to mount. But in basic terms, you know, yeah, you can't even really put a number on this, but think of it as if, you know, in the middle of March, all of a sudden, healthcare utilization went down by 50%, and the 50% that was left was half telemedicine. And then it slowly kind of climbed out of that hole with all kinds of variation on both sides of those general numbers. But one of the things that we did learn is that even though telehealth is perceived commonly as a rural phenomenon, it really isn't. It is used just as much in urban areas, if not more. And in this particular data set that Ativ Malhotra and his colleagues published in the Commonwealth Fund newsletter and other places, they found twice as much telemedicine by percentage going on in urban areas as in rural areas. So it's just not for rural areas anymore. The other thing that we're starting to see, and I'm using a lot of this team's data just because it points out, I really like the way they pulled apart that overall response into pieces, so to kind of see that, again, to my earlier point, telehealth, the telehealth response to COVID-19 was not just one thing, and that it splits out, that we saw variability by patient age as to who was getting back into the clinic and who wasn't. It varied by age. It varied by specialty. Specialties responded differently because they were differently set up. And one of the things I'll point out, because we're talking about telebehavioral health today, is that teal line, that behavioral health line. Very interesting range of responses across the behavioral health community. In some ways, we, speaking very generally here, were better set up for telehealth. There were more of us in the behavioral health world that were ready to do telemedicine. But at the same time, certainly not all. And one of the things that we see that these data show is that there wasn't as low a drop in behavioral health right off the bat, but there also wasn't as robust a bounce in behavioral health. And I think what it's pointing out is that the behavioral health world is extremely varied as well. And there are some services that were less likely to rebound, in the sense that they just weren't seen as sort of essential services. I sure don't want to get into talking about whether behavioral health is essential or not, but there were a lot of behavioral health encounters that I think patients just kind of said, you know what, it's optional, we're in lockdown, I'm not gonna worry about it. I think also, though, there's probably a significant section of those folks who were able to use telehealth, but we are starting to see now in some of our data a group of users who technically have the capability, but are more reluctant to follow up with a telehealth encounter. And so that's something else we're going to have to address. Just a couple more options that these data showed. And this one is of particular interest to me because I work with a lot of health centers, federally qualified health centers. And in Ativ's data, this is from Phreesia, which is a patient engagement platform that covers a lot of different types of providers and different payers. But they found a higher residual amount by percentage of telehealth being done at FQHCs than non-FQHCs. And it's very early. We can't say this definitively at all, but I'm curious about this, and I have my own hypotheses about why we're going to see safety net providers engaging more rapidly and hanging on more strongly to telehealth as a delivery modality. But we can leave those discussions for later. One of the things that I want to point out about the pandemic and telemedicine in general, and again, if this is old hat to everybody by now, I apologize, but so many more people now have experienced telehealth, understand what we mean by telehealth, at least some kind of telehealth, whether they saw their doctor or they heard about someone who did. What we're seeing now, we used to talk about, and still do, talk about domains of telehealth, different kind of business models, ways that you use the tool, like, you know, crescent wrench versus a box end wrench versus a socket wrench. sorry if you don't know any of that terminology. I grew up as a shade tree mechanic and love the stuff, but these are all very different ways of using telehealth. And so we can talk about different domains. By far the largest domain that awakened and exploded during the pandemic was this direct-to-consumer services. And direct-to-consumer actually probably bifurcates pretty clearly between providers that only do direct-to-consumer care. These are large groups like Amwell and Teladoc and Doctors on Demand, who've been doing this for a while and are set up to do this outside of the kind of bricks and mortar system. And on the other side, bricks and mortar docs that had to suddenly rapidly develop the capability of seeing people at home. What we would have called previously direct-to-consumer care, because the largest proportion of telehealth before that time, although the scale was tipping, but the largest proportion before that time was basically site to site. You would see a telehealth doctor at a clinic, not at your home. Again, that was growing. It was shifting, but the explosion that happened primarily happened in direct-to-consumer services. Telehealth. I always try and make the distinction between telehealth as a tool and telehealth as a treatment. Telehealth is not a treatment. I don't have a headache or heart disease and say, well, let's see if telehealth will help that. Although it's easy to slip into that kind of thinking, but we end up thinking wrong about it. It's a mechanism for delivering services. Access to healthcare can impact outcomes, but telehealth by itself doesn't impact outcomes, right? Only if it leads to more access to healthcare. So we just need to keep those things straight. Also, a lot of telehealth is regulated at the state level. There are federal regulations in place, but most of those regulations have to do with healthcare. Generally, telehealth itself, the practice of it, is primarily regulated through licensing boards. And so that's why we have, and then the payment of it is primarily regulated through payers or payment policies happen through payers, which are then regulated at the state level, primarily outside of Medicare and some other federal plans. So it really does vary state by state, and there's a lot of variety. And for people who are new to the telehealth world, I guess, sorry about that, but it is complicated. Who knew healthcare was complicated? Primary implications when we start to use telehealth, that our scope of practice is the same, but it occurs at the patient's location. We need to be aware of that as far as licensure goes. We have to, of course, maintain, I don't suddenly develop new superpowers now that I'm using telehealth, other than I could see somebody across the country, but if I'm not licensed to see them there, I legally can't. My licensure is geographically bound, and I need to respect that, even if my technology will let me see anybody, anywhere, anytime. If I'm only licensed in Indiana, which I am, then that's where I see people. As far as ethical requirements, most of the, and I talk about the behavioral health world primarily, and I'm not necessarily an expert in the world of medicine, but most of the behavioral health boards will talk about basically extending the same set of ethical principles to the virtual environment, which includes evaluating whether telehealth is the right tool for this situation. And you're always weighing it off. There are access issues in the pandemic. Okay, maybe telehealth wouldn't normally be the right tool in a certain situation, but if people can't travel and seeing them is better than not seeing them, a telephone call is better than nothing, then we make that decision on a case-by-case basis to evaluate the appropriateness of telehealth for this patient, this situation. We also are obligated as behavioral health providers, certainly, and I'm sure any kind of healthcare provider, to have done some thinking about an emergency response and safety plan, with the recognition that we're talking about safety at the patient's location, not our clinic. I mean, we'll have plans in the clinic if somebody, has some sort of adverse event in the clinic. But now with telehealth, we need to be thinking, okay, what happens if they start choking or there's some other emergency that develops at the patient's location when I'm not there? And it doesn't mean we have to have a way to solve it. We just have to have some steps to take. And those steps primarily involve getting somebody locally connected and who can intervene for us. I mean, that's again, very, very broad generalization. But that's the gist of it. Do I have emergency contact information for, you know, somebody in the house, for local EMS, local fire, whatever, just so that I have access to that and I've done some thinking ahead of time of what I would do if one of those 1 in a million situations develops. Identifying ourselves and confirming the patient's identity, something we do all the time in clinics, but sometimes virtually it's we need to think ahead of time and have processes in place to do that. Those of you who are developing, you know, have developed quickly telehealth programs have recognized that these are things that come up. And then we also have to understand the implications for privacy and confidentiality if we're going to use a platform. We may not be software experts ourselves, but we need to have somebody in our organization, or somebody, if you're in private practice, some organization that is on the hook to ensure that what you're doing is maintains an adequate level of privacy and security according to all of the regulations that that within which we operate. Again, this is probably not news to any of you, but you know that under emergency waivers, we have a lot of federal flexibilities, a lot of states followed suit. And I would say too, that that's why today, the vast majority of the telehealth that has sort of introduced telehealth to the world, so to speak, the vast majority of that only exists because of flexibilities that are in place. There is some that is an expansion of what was already possible prior to the pandemic, but because of those flexibilities, we can, you know, see Medicare patients at home. There were only a few that we could before that. We can use audio only care. I mean, all kinds of things that are only possible now. And I think it's important to underscore, and I know many of you have heard this underscored before, if and when those sorts of things, I mean, we're going to enter after the pandemic, as the pandemic recedes, we're going to enter a new era with regard to healthcare and telehealth, as states and other entities, payers, federal, CMS, figure out what is healthcare going to look like. How are we going to use telehealth? How are we going to incorporate it? How much flexibility are we going to give? How are we even going to conceptualize it going forward as an essential part of care, as an essential part of access, or as an optional nice to have, or only possible when you document, you know, limitations otherwise. I could summarize those flexibilities, and that's kind of what this state is about, or this page is about. Medicare has some specific emergency waivers about making patients eligible and location and all of that. I'm going to skip this just because I think these lists are available. You'll have access to these slides if you want them here, but you can contact your TRC. There's a lot of detail that's kind of hidden. This is, I just, again, was trying to give people an idea who hadn't gotten into this before, what sort of flexibilities we're talking about and what we can do now. So I'm sorry if this is, boy, this is what I came for, all of this detail. Follow up with me or with Janine and we can get you all this detail. To summarize all of that, we've got an expanded range of services that we can do not only by video, but by telephone. Asynchronous or portal-based services, e-visits are covered. Interestingly, though, my understanding is that that these are being less used by a lot of providers for a number of reasons, and we can talk about that if you have questions. Patient's Home now is very widely available as an originating site. We don't have to go into the clinic to use telemedicine. We got a lot of flexibility as far as technology, which, well, we can talk about that in more detail too. One of those flexibilities, of course, is with audio only care, realizing not everybody has access to live video, and we still want to have them be able to talk to their doctor or provider of any kind, behavioral health provider. We got one of the barriers that we realized right away is that if you don't have people coming into the desk and filling out paperwork and signing consents, how do we handle that if they're not coming in to the clinic at all. And so we've got a lot of flexibility around consent and new patients and enrolling new patients and being able to see new patients. And as I said before, most telehealth that is going on now, I believe, is taking advantage of one or more of these flexibilities in some way. And so all of it is at, well, a large proportion of it is at risk going forward. Not, not surprisingly, there's been a huge increase in telehealth use, although it is receding a little bit now, mostly to patients' homes and using their cell phones. Many patient barriers, technical barriers still exist. It's one of the tragedies of inequities in healthcare is that, yeah, it's hard to take off work and put gas in your car, get on the bus and get to the doctor. It is also hard to pay for a cell phone plan that gives a lot of minutes and has good connectivity and you have a nice device so that you can see your doctor. Telehealth overcomes some barriers, but not others. And those barriers still exist and we're still working to overcome them. Physical challenges to accessing telemedicine care have certainly become apparent. We realize how little private space people have, although having access to their private space to see them has certainly been a boon for many clinicians who understand their patients' lives at a much better level. And I'm sure there are dozens, hundreds, thousands of stories out there about that. Providers and clinics are facing unprecedented revenue shortfalls. That's not necessarily a topic that we're talking about today, but it is certainly something that is on the minds of anybody running any kind of clinical operation at this point. We all had to stand up telemedicine services, almost all of us, rapidly. And many people are struggling to figure out, how do we do this? How do we do it well? How do we do it effectively? Can we do it better than we're doing it now? We also recognize there's a risk. Some telehealth is going to subside after the PHE. We don't know exactly what. Audio certainly is one that's at risk, audio only care. I've been involved with a group or two that is starting to think about what are we going to do with audio only care going forward. And then regardless of all of that, we are going to be doing more telehealth in the future, and we're going to have to get more comfortable and better at it. And that's part of the reason why we focus on training as much as we do, and why opportunities like this ECHO exist. I will summarize just a little bit of what we're hearing, and this is not necessarily behavioral health specific. A lot of what I've said today isn't behavioral health specific, but we are hearing overwhelmingly positive feedback. Not that there aren't negative aspects to telehealth, but both doctors and patients are saying this is fantastic and we don't want it to go away for a lot of good reasons. It's also not ideal for a lot of reasons. And there are still some slow adopters and some patients who are ready to be done. I hear that mostly, interestingly enough, from outpatient psychotherapy patients, but then again, that's probably a selection bias on my part. The providers that I've talked to tend to be, or there's been a large number of them that are outpatient mental health providers, and realize that there's something to the office encounter that they're missing. I'm sure a lot of other doctors are missing, a lot of other providers are missing the office encounter. But they're also recognizing that it is something to be able to see all my patients from my office at home or from my couch or from my, wherever. There are a dizzying array of new workflows that are being created and developed as providers and staff kind of get comfortable and say, what else can we do with this? How could we use it to solve this problem? And so we're going to see a lot of that, I expect, see a lot of that diversification of workflow. It's another question that we get asked a lot. Give me a telemedicine workflow. And it's like, well, workflow, it's like building with blocks. Which blocks do you have? We need to put them together, yes, but if you have different blocks, if you structure your clinic operations differently, then not everybody's workflow is going to work, or not, a single workflow is not going to work for every clinic. But there's been a lot of creativity and innovation in that space. Some patients can't or won't use technology. We're of course realizing that enrollment signatures and all of that can pose problems. and that sustaining revenues is going to definitely be a problem. I think in the past, and this is, I think that what we have always had to recognize that the kinds of services we deliver and we provide have been driven by providers in a significant way. And what I mean by that is we as telehealth resource centers, for example, have been encouraged to help people advocate for their own, help patients advocate for using telehealth. And what we've kind of had to push back a little bit with HRSA on is say, you know, patients could advocate for telehealth, that's great, but ultimately the doctor has to provide it. It's a little like helping patients advocate for evening hours. I mean, that's great. You want to use evening hours, but unless the providers are on board, you're not going to get evening hours at the clinic. And that's just, you know, one small example. What we saw with the pandemic is that all of a sudden, all of those barriers on the provider side, many of them were eliminated. And not only that, there was a tremendous need. If we're going to sustain healthcare, we're going to have to figure out telehealth. And we dug deep and did a lot of, and created a lot of innovative programs. So we had one set of barriers that were kind of overcome very quickly. We have another set, the financial set, that are kind of temporarily being helped out, although certainly I don't think anybody's saying we're getting better pay now than we were before. We're going to have to solve that set of barriers too, going forward. And payers have their own set of concerns moving forward. I won't dig into this much, but we are. It's going to be an effort. It's going to take some effort on the part of everybody in the healthcare community to figure out how we're going to use telehealth going forward. I'm going to stop there and say that's what I had prepared, and let's see if we want to have some questions and some discussion, see what kind of time we have. Janine, orient me as to where we are and what we want to do next.
All right, so it is just about 9:45, so we have a few minutes ready left for questions. So if you have questions concerning Jonathan's presentation or anything that you would like to ask Jonathan, because he is a wealth of knowledge, please go ahead and do so. Jonathan, I think that last slide is so true. It's, you know, as we move forward, what we're seeing are providers frightened that they're not going to get paid for telehealth anymore. And that some of that may be true, and then some of it may be, you know, hearsay. So what's your best advice for those who have started telehealth and thinking that I'm going to have to just not do this anymore because I'm probably not going to get paid?
Oh my goodness. I wish I had a good answer for that. My sense, and those of you who are providers, or even, well, those of you with a significant amount of experience in the telehealth world, it's easy for us to believe that, oh my goodness, this is never going away. And that's what everybody's saying. This is never going away. I have said this in the last few minutes. This isn't going to go away. But I also every now and then get into a conversation and hear things like, I was with some primary care folks from NAC the other day, and talking about conversations they had where officials from CMS were recalling how, you know, there was that transition in the last few months, and they said, oh my goodness, we're paying you $95, $92, whatever, for a telephone call. I can't believe we're doing this. And on the one hand, I understand, yeah, you're paying $92 for a telephone call. That's crazy. On the other hand, it's like, if that's the only thing I can provide out of my clinic, I'm not going to be able to sustain it on $92, you know? And so there's this, it is a monstrous set of challenges that we're going to have to address here. And beyond saying that, I mean, we can talk about what details, who's in the ascendancy now. I have to say, my own take, and there are people with deeper roots than me on this call, but my own take is that telemedicine has remarkably been a remarkably bipartisan issue. I mean, there's been a lot of support for telemedicine in the last, certainly in the last 4 years, this administration, and I expect it's not going to go away going forward. So we have a lot of that on our side, but we were also locked into, we are sort of in the process of moving from volume to value and a number of other sort of currents here that makes for a multi-dimensional challenge here, trying to figure out how we're going to pay for this. Audio only has shown that it is a useful thing, that it will be used, but how do you pay for it without, and how do you pay for it in the context of the way we pay for telemedicine generally? That's a challenge. Now there are a number of answers or a number of possible directions to go. I'd say hang in there, and I'm still pretty optimistic that we're going to figure this out. Nobody's going to cut the legs out from under healthcare. It's such a huge and important service in our country, but we just don't know yet where it's going to land, and partly because there's so many other things landing at the same time right now.
Yes, absolutely. Evelyn has a question in the box, the chat box. Evelyn, do you want to ask that, or do you need me to read it?
No, thanks, Janine. Great presentation. One question that came up in one of our fall presentations was about reimbursement related to ABA services. I just was curious, you know, what your team's experience was with coverage for those behavioral services.
You know, GP track is not terribly well exposed in that domain, so I really can't say a whole lot about that. And maybe I should just stop there. I think like a lot of other services, we there's growing evidence that this is that is useful and helpful, and we got to figure out some way to pay for it. But remember, mental health services, as you well know, Evelyn, mental health services are useful and helpful, and we've had trouble paying for them for years. So
well put.
Yeah, I don't expect we're going to suddenly solve that problem.
Karen.
I just wanted to make a comment about the bounce in dermatology. I'm a dermatologist, and I did teledermatology for 26 years before I retired. And I know something about that. What happened was we had good technologies mostly. So the two things that made people keep using it are frictionless technology and then help with the workflow. And lots of people had that. But what we saw, what I've heard from my friends around the country, is they wanted to keep doing it and the patients didn't. So many of their patients wanted to come back and see them in person. And so it was hard to kind of keep that workflow where a lot of your day is telederm when patients are knocking on your door. So that's add that.
That's not unlike what I heard from the outpatient mental health community, and this is a small sliver. Mental health is big as any domain, but that in-office experience for some specialties, some services is a big part of the experience. Yeah.
Any other questions? This is your chance. Well, excellent. Jonathan, we really appreciate your giving of your time and your expertise to this telemedicine echo that HTRC and MTM has put together. And we invite you back anytime that you want to join us and check in and be one of our experts on a panel. So our next Project Echo is actually February 9th, and it will be school-based telehealth.